be exceptions that prove the rule. We're getting away from it now, but there used to be patients who had a standing order for some sort of a sedative agent every time they had a medical appointment or a dental appointment. And really, this isn't particularly effective or particularly safe, because also remember that the patient isn't being monitored while they're being transported. There might be just someone driving the van and the patient's in the back with medication on board, and this is not a good situation. But the exceptions do exist. There are patients that respond really well to low levels of lorazepam, for instance, and one of the reasons is they're not taking any other medications, and they just happen to respond really well to low levels of lorazepam, probably because anxiety, in this case, was the barrier to cooperative behavior. So if we look at the Special Care Dental Association members and who does what, because I think this is a pretty good gauge of, do I know what I'm talking about? Well, maybe I do. Am I an outlier? Sometimes I'm in the mainstream. What are people doing out there? So look at, Special Care Dentistry Association members' use of pharmacology. Oral sedation. 30% of people who treat people with special needs and responded to this survey in 2011 never use oral agents. 53 sometimes, and 17% often. And I really have to question this, because maybe my experience is different, but I do not think that they should be used often, because I don't think they work that well on most patients. What about nitrous oxide, which would be the next thing we might think about? Here are the American Academy of Pediatric Dentistry, and again, we're not treating pediatric patients, but much of the research comes from the pediatric literature, okay? The American Academy of Pediatric Dentistry indications for the use of nitrous oxide. Fearful, anxious, or obstreperous patient, which I love. This kind of means ill-behaved. So I'd like to tell a parent that their child is obstreperous. Certain patients with special health care needs. Doesn't say which ones, okay? So do we try it? Well, maybe. So it does have a role. But with nitrous oxide, you have to have a patient with a base level of cooperation, because if you've ever used nitrous oxide and oxygen, or if you've ever administered nitrous oxide and oxygen, you know that it's not all that simple. You have to have a patient that's willing to wear a nasal hood and has to be able to understand the command of breathing through their nose. Because if they do not breathe through their nose and they breathe through their mouth, the nitrous oxide is not sedating anyone, but it's sort of getting into the room, and it's having an overall effect of everyone in the room. Many people feel very constricted when they're wearing a nasal hood. We're going back to the positioning and the tactile defensiveness and all those things. So on some patients you can use it, but it isn't really used widespread because it isn't particularly successful. It's also difficult in an institutional setting, meaning if you are in a hospital, for instance, nitrous oxide is put in the same category as general anesthesia, and there are very, very stringent regulations. So it's difficult from a logistical standpoint. Also, certain contraindications, nasal blockages, hiatal hernias, all these things, psychiatric disorders. You typically do not want to disinhibit someone with a major psychiatric disorder, which is one of the things that nitrous oxide does. And many patients, especially patients with Down syndrome, who have, anatomy that makes it difficult to breathe through the nose, are mouth breathers. So if a patient's a mouth breather, they're not breathing through the nose, you really can't use nitrous oxide effectively. So the bottom line, again, from my friend Nancy, is not very useful in patients who are extremely fearful and display markedly disruptive behavior. So it might be an adjunct, but it's nothing that's really going to get you very far in truly uncooperative patients. So the members of the SCDA, again, nitrous oxide, 37% never use it, 43% use it, and 20% use it often. This is a lower percentage than people who are sedating with oral sedatives, I guess. What about IV sedation in special care? Well, there are a couple of drugs that were developed maybe 20 years ago or so, and they've made IV sedation much safer and more predictable. Midazolam and propofol are the drugs that are typically used in oral surgery for sedation. But again, establishing an IV requires a level of cooperation. So if a patient won't get into the operatory, you're not going to do an IV sedation. If a patient won't sit in a chair or a patient won't sit still long enough to have an IV started, you can't do an IV sedation. And oral surgeons are less than comfortable with the use of water spray because remember that during an IV sedation, the airway is unprotected. Now, I'll get into general anesthesia in a few moments, but with general anesthesia, a person is intubated, so they have a protected airway. We still need to make sure that we don't get water and debris down their airway, but at least it's protected. With an IV sedation, it is not protected, and using a water spray can cause aspiration, which can lead to a pneumonia. It can cause a reflex of, what am I trying to say here? A laryngospasm that can be very dangerous. So oral surgeons don't mind taking teeth out under sedation, but they're very hesitant to even administer the sedation so that general dentistry can be performed. So we've gone through all these things. We've tried behavioral guidance with medical immobilization. They haven't worked. The oral agents are not effective. The patient won't tolerate nitrous, and they don't have a level of cooperation for IV sedation. So what do? Well, there's only one thing we have left. We have potentially taking the patient to the operating room. And I say potentially because this has got to be a big debate. Just because a patient needs some sort of minor treatment and has been unsuccessful in receiving the treatment at those previous modalities does not necessarily mean that they should be treated under general anesthesia, okay? So this is my stuff on general anesthesia and special care. The literature does not say very much, but there were special care dentistry clinical guidelines for people with special needs. These are now, quite old, but there are some important points here. Conditions such as intellectual disabilities are not in and of themselves indications for general anesthesia. That sounds very obvious, but if we go way back to the first lecture of the year talking about deinstitutionalization, there was a large group of people in the 1970s and even the early 1980s who used to be in institutions and were suddenly in the community and going to community dentists. And many of these people were quite uncooperative for dental care, partially at least because they had no history of receiving any dental care other than possibly under medical immobilization in their institution. So lots of people were scheduled for the operating room to sort of get a baseline, even a good examination and x-rays. And that sort of perpetuated for a while, and people who were unable to be examined thoroughly with radiographs were sometimes taken to the operating room in the absence of any actual indication that there was a real problem. This is not what should be done. The decision should be made with respect to a patient's behavioral capabilities, their desires, the desires of the family and the guardians, and their treatment needs. So back to Dr. Doherty, who tried about 10 years ago or so to come up with indications for treatment under general anesthesia. And the bottom line she came up with was that evidence in this area is not sufficient to provide a basis for guidelines. So I give her credit for trying, and I give her credit for saying in so many words that we don't have enough evidence to establish guidelines. The decision remains as much an art as a science. So this is a little bit disconcerting to me. This article says that the estimates of the number of patients this is patients with intellectual and developmental disabilities, who require general anesthesia, estimates vary from 80% to 11%. Well, certainly 80% is way, way, way too high, keeping in mind that about 85% of these patients have mild intellectual disabilities. I think 11% is too high. The figure that we typically use in the New York State Task Force for Special Care Dentistry is 5 to 10%, and 5% is probably more accurate. So we're not talking about a large group of people, but we're talking about a small group of people with very severe treatment needs and severe behaviors. Here are the take-home messages. General anesthesia in special care is the treatment of last resort, and the risk of anesthesia must be outweighed by the benefits of treatment. Twice, just so you remember it. And here are my editorial comments. The significant need and significant anticipated benefit must both be there. It should not include EUA, which is exam under anesthesia, without an obvious clinical indication. Again, there are some people who used to, and a smaller group of people, dentists that is, who still will take someone to the operating room because they can't get a good examination in the absence of any indication of any problem. There is a very small group of dentists who at least used to take patients to the operating room under general anesthesia every 6 months to do a 6-month recall. This is not appropriate. Again, this is my editorial opinion, but I don't think it's appropriate because in that case, there is not a demonstrated significant need and there is not necessarily a significant benefit, and the risks are substantial. Okay? So if you look at this patient, this is certainly an unsightly situation. They need something done. Do they need it done now? I don't know. With this level of hygiene, if you scale these teeth and the level of hygiene does not increase, you're going to see the same exact clinical picture, sometimes in weeks and certainly in months. So what was the benefit if the patient is completely asymptomatic and functioning well and there's no indication of an acute infection? I don't know. This patient's a little bit different. If this patient comes in, you certainly can make the argument that they have significant need and there is a significant anticipated benefit. In this case, the significant anticipated benefit will be the avoidance of future pain and infection, as well as if the person has any systemic indication or conditions such as diabetes. Certainly there would be comorbidities that could be affected by the condition of the oral cavity. So I don't think anyone would argue that this person needs to go to the operating room. It would be a reasonable thing to do. If the benefits outweigh the risks, and only if this is true, you need to do a few things. You need to make sure that everybody understands what is involved. So you need to educate everyone. That might be the referring dentist. It certainly is going to be whoever's caring for the patient, both in terms of family and friends and in terms of caregivers. So you need to understand that this is a serious medical procedure. This isn't just, oh, he's just going to the dentist. It just happens to be in a hospital under general anesthesia. And you also, very importantly, need to make sure that everyone has realistic expectations, including caregivers and family members and the patient to whatever level the patient has the cognitive ability to understand, okay? Don't get talked into things